Okay.
Thank you, Chair.
Thanks, Mark.
Councillors will be familiar with the format of the presentation, so I have a few slides that I'll work my way through just to share in terms of where we're at from a Southwest Acute perspective and briefly on OMA as well. Go ahead, Chris. So look, ED attendances is something that focuses all our minds at this present minute in time, given the press in and around the particular challenges. But one of the things that we wanted to do in and around the temporary change to emergency general surgery was make sure that our A&E department continued to be busy. Year on year, we are seeing our A&E department continue to be busy and serving the needs of the population in the locality. Also, despite the fact that emergency general surgery admissions have moved to Galvin Hospital, we also see a rise in the admission rate also to Southwest Acute Hospital. And consultant outpatients continue to be at a very high rate across the organisation as well. And we know that outpatients aren't just made up of consultant and middle grade doctors, it's also very much about our AHP family as well too, in terms of physio, OT, etc. Go ahead, Chris. Obstetrics and gynae was obviously an area of concern for the general public as well at the point of the temporary change, and we continue to see live births year on year, but very similar in terms of delivery and demand. And just to say as well, I suppose from an obstetrics and gynae workforce perspective as well, we have a full tier of obstetrics and gynae consultants in place in Southwest Acute Hospital as well. One of the things that we did at the outset of the temporary change was implement emergency surgical assessment. We have a very senior tier of surgeons still remaining in Southwest Acute Hospital. These are not consultants, however, do have the ability to see, assess and review patients, both referred by GPs and directly from the emergency department, with a very good link up that we have to diagnostics and radiology from an ultrasound perspective and CT. And year on year, we're continuing to see those patients who are using that service increase. We actually think that there's probably scope for more activity to come through that unit. And more recently, myself and Dr. Ahmed Marzouk met with the GPs in the locality to explore opportunities that we can both work together on as we move towards the future. Having care close to home for our patients is really important as we move forward. And we know that this is a very good service, and actually a service the evidence will tell you that patients like, because they can have their treatment and care as a day case or a ward attender without the need for admission. And that makes for very good efficiency from our perspective as well too, in terms of using the beds and the capacity that we have in the best way possible to avoid any significant delays. Go ahead, Chris. So just an update then on emergency general surgery. RQIA, as you will know, the aim was to review the effectiveness of the clinical pathways with a view to identifying any aspects for improvement. The report was published in January 2025. The report itself did not identify any immediate patient safety concerns and identified 10 recommendations that were to be brought forward. And that was agreed in principle by the department and by the trust. Since that, RQA have also attended trust board. If I can just bring you back to some of the particular aspects within the report. They talked about stabilization of the workforce at middle grade, particularly those doctors that I talked about who operate within surgical assessment. They talked about reviewing the need for locums and trying to eradicate locums. Since the review and since the report, we've moved positively in the direction of eradication of locums at that particular grade. And those doctors now do not just work exclusively in Southwest Acute, they actually rotate into Alton Galvin. So what we have is a very resilient workforce where doctors get good supervision and good support from consultants at that level as well. RKA also talked about a very clear clinical audit process. And again, since the report, we've undertaken a continuous audit cycle. And from that audit cycle, we've also identified new pathways for head injury, where patients can have their care in Southwest Acute without the need for transfer to Alton Galvin, where a period of observation is required. But also when we looked at some of the surgical presentations, we identified a number of opportunities for patients not to have to transfer, but to be booked into Southwest Acute Hospital or OMA on an elective basis given their particular presentation. And that was around patients who required gallbladder surgery and some patients who required incisional drainage of wounds. Work ongoing, and that's not just a two-way process either. We can use those pathways from an Alton Galvin perspective, and we can actually book those patients attending Alton Galvin ED into OMA and Southwest Acute Hospital as well. We've also been very focused on the patient experience piece as well. Our QAA suggested that we could be more purposeful in terms of how we went about that. So we have now written to every patient in January, every patient in February and March, to ask them to give us their feedback, and we're in the process at this present moment in time of developing that into core themes, and we will be in a position to share that probably at the next council meeting, if that's okay. Next slide, please, Chris. Oh, sorry, ring fence beds. One of the biggest areas of concern for the population and the patients of Tyrone and Fermanagh was going to ED. Since the 24th of May, the percentage of patients going directly to bed has increased to 79%, and that's very clearly evident in the flow chart that we have. However, it's also important to point out that not every patient will go direct to bed because that is very much based on clinical priority and a decision that is made by the surgeons. However, we are exploring the opportunities within Alton Galvin site to expand the bed capacity to make that a more seamless journey moving forward. Go ahead, Chris. So, graph just simply shows the improvements that we've made from the point of view of direct to bed. There can be weeks where it's 100%. There can be other weeks where it dips down depending on pressures. Go ahead, Chris. So SWA rebuild then, obviously very focused on the overnight stay piece, very focused on maximising the opportunities and the operating capacity and capability within Southwest Acute Hospital. And I have to say, I believe we've made very good progress from that perspective. Session numbers increased from 457 in 23-24 to 635 in 24-25, an increase of 38% with 411 more patients being operated on. Really important infrastructure from our perspective, not just from the point of view of utilising the theatres, but given the waits that we have for patients who are awaiting elective surgery. Also very focused on the operating time as well as we move forward. Over the next 6 weeks, we will see Southwest Acute maximise all its capacity and actually on weeks over exceed the commission volumes as we move forward. So we are seeing paediatric surgery there, paediatric dental surgery, special needs dentistry, general surgery, gynae surgery, breast surgery, and more recently, as you'll be aware, ENT surgery came to Southwest Acute as well. Go ahead, Chris. And then just OMA. OMA is achieved 82% of its activity across 24-25. The number of sessions increased by 3%. We have still further work to do from an OMA perspective, and our numbers are not where we probably wanted them to be because we were working with staff to extend the theatre day and extend the working day. That is now in place, and we are hoping that as we move forward into the rest of this year, we will see a significant increase in the OMA activity. I suppose also important to note as well, from an endoscopy perspective, we have seen a significant improvement in endoscopy access, both in Southwest Acute Hospital and in OMA Hospital as well. And as I'm sure everyone's aware, that's part of a red flag pathway. So really good improvements from an elective care perspective, but still some work to do in that space to maximise every opportunity. Thank you.
Thank you very much, Mark.